Okay. So these are the resets, and again, even this is only an upper quarter course, I'm going to give you all them all. And these aren't comprehensive, but these are shortcuts. And I've verified these with several Mackenzie diplomats that these are the directional preferences for most joints. So for the ankle, most people have a loss of what? Dorsiflexion, right. And most people stretch into dorsiflexion, right. So guess what helps them? Plantar flexion, right. I have a loss of dorsiflexion. So one of the SFMA breakouts, and this has been tested to be pretty reliable, shoes off, you can do a fist or about 5 inches away from the wall. Your knee should easily be able to touch the wall. Mine would miss. My good side, and this is the side that I didn't have knee pain on. I had knee pain on the other side. I can easily touch, okay? So before I go for a run, I do about 10 to 20 end range plantar flexion. Sometimes you can do a little inversion, whatever feels more comfortable. I feel like this is a better stretch. A patient might feel like it's actually uncomfortable. If inversion makes it a little bit more comfortable, that's fine. Or if it gets them to a better end range, that's fine, because end range is where the magic happens. You would never think of doing this, and I thought, I would never think of doing this either. When Mackenzie Tip showed this to me, I'm like, there's no way in hell it's going to work. But it does. Very well. So that's a very quick thing that I do before I run. All right, for the knee, typically most people have a loss or pain with flexion, right? Usually closed chain activities. So guess what the reset is? Extension. And I even check that passively because when someone's going to respond to extension, you're supposed to have about 10 degrees of hyperextension. So when I have them lying down on the table, I just check that little joint play at the end, and often the involved side has that little loss of extension. So I'll just start someone off just actively, doing open chain. But as long as they can tolerate that, then I rapidly get them into kind of a more closed chain, passive knee extension. If you want to, do screw home a little bit, you can externally rotate the tibia as a modification. So 10 times an hour for each one of those. For the hip, sometimes it's extension, except for the problem with extension is most people have tight hip flexors. And most people are stretching into hip extension anyway because they're always trying to stretch their hip flexors. So for someone with like an FAI or femoral acetabular impingement, it's actually not extension. Guess what it is? It's flexion. So it's a variation on flexion, and if that is actually pinching, again, if you have an FAI, this may pinch a bit. You could also do a little flexion and abduction in external rotation. That enables me to go just a bit further. I mean, there's certain people who may need a little bit of IT band work or quad work or a quick psoas release, and then they just do this for maintenance. Or for your restored extension, you can do that for maintenance too. But in general, a quick flexion seems to work pretty well because it's, again, a direction contrary to what most people are stretching in. For the lumbar spine, it's usually, for bilateral or symmetrical, it's extension. And again, with extension, you're looking at going to end range. So I don't expect that of most people, and even my business partners, like for our pictures for our clinic, he's like, could you not bend back so far? People are gonna break their back or something. But it's always end range, right? You don't always have to look like you're dodging bullets in the Matrix. For unilateral symptoms, again, the first thing I actually check is side gliding and standing. So any kind of unilateral hip, knee, ankle pain, first thing I check is loading. So side gliding is named for the side the shoulders are going to, not the side the hips go to. People document that incorrectly all the time. You want to think of osteokinematics, right? People get this wrong, but they don't get this wrong. You wouldn't call this side bending left because the hips are going left. Osteokinematically named for the way the superior vertebrae is going, or the shoulders, which is the same thing. So even though my hips are going left, my shoulders are going right. The reason why this works better as an end range is because there's typically rib approximation on the iliac crest first. You can't get to end range this way. This way you can get to better end range. So they can do that in a doorway or against the wall, 10 times an hour. They may have to vary. If they're getting really a lot of pain with loading and closing, they can flex a little bit, but in the end, you want to do in an upright and eventually progress to extension. For the thoracic spine, the best thing is the ballistic whip. So actually, let me get someone else up here. Anyone else thoracic stiffness? You had thoracic stiffness, right? Okay. You want to have a seat? Okay, actually face that way. Well, let's just quickly check. Interclasp your hands behind your head. Good. Rotate to the right. Rotate to the left. So much for thoracic stiffness. He perceives thoracic stiffness, but anyway, let's just try it on you and get you ready up here. Okay. So, interclasp your hands like this now on your sternum. So the key to this is hands on sternum, because when he does the ballistic whip, you don't want the hands to leave the sternum. Otherwise, all you're doing is very fast scapular retraction, and you're not getting the end range thoracic rotation. If your patient likes to be manipulated, they're going to love this. And this is why, typically, again, if you have a true thoracic patient, as in you screen cervical, you can't reproduce it with cervical, this doesn't make them better repeatedly, this doesn't make them better, or this doesn't make them worse repeatedly. They have trouble with deep breath, they have trouble with coughing, potentially maybe pain around the rib. It's usually unilateral. Unilateral loss of rotation one way. You choose the loss first. Typically, I would probably do some tissue work and manipulation to that area, and then have them do the ballistic whip. But you will need to. Maybe it's someone who doesn't want tissue work or doesn't want a manipulation. This works really, really well. You're talking a 2-visit thing, show them this, they're probably going to feel better rapidly because it's a very mild condition. That's why it doesn't show up in our literature. You know, the effects of thoracic pain on workers' disability. We don't really see that. So keep your hands on your sternum. You give them a target. Whip as fast as you can and hit me, hit me, hit me, faster, faster. And all I do then is he's already to go pretty far. Good. And relax. That's all they do. You might feel a lot of whips or cracks and pops with that, and that's great. You're not breaking anything. Many people do that often anyway. The speed makes a difference with that. Faster. Faster. Come on. All right, not bad, not bad. For patients, I start with the target here, and as they're able to go a little bit further, you already had full motion. I just gradually move my hand back to midline, and that gets them going to end range. Then to do that, only in that one direction, 10 times an hour. The next visit is to make sure that you're still okay, because typically they're still okay if it's only thoracic. All right? Thank you. For upper thoracic, come over to the wall. There's 2 ways. Fingertips, anywhere in upper thoracic. You can lean against the wall. As long as they have good symmetrical shoulder range of motion, you're using shoulder elevation to give a little P to A just for upper thoracic. Now again, my thoracic spine is very stiff, so that's not a great example on me because I'm pretty sure that was only lumbar extension and I wasn't getting a lot of motion here. What works better for me, I'm going from the side here, is against the chair, and I can just backward bend lightly over the chair. And I'm trying to keep my back as flat against the chair as possible, just to isolate that to upper thoracic. I've also done that over a foam roll. Now you can pick any spot on a foam roll and just do repeated extensions on the foam roll. And when I do repeated extensions, I usually drop my buttocks to the ground just to kind of get a backward bending from both sides. So in addition to just rolling on the foam roll like a lot of people do, I think it works great to do. Just giving yourself repeated P to A's, you know, just like you would do to a patient. They can replicate a lot of this stuff on their own too. Come around here. Thanks. For the shoulder, it's going to be repeated extension. So actually mine's still pretty good. That's pretty good too. But you're going to tell them to put one hand behind your back to keep the shoulder square. When they start rotating this way, they're not an extension. You want it to be in as much extension as possible, and they could do a squat or a lunge. So this chair is really low. You know, if you have a higher bar, like we have a bar to clamp goes up and down, you attach cords to, and you typically use that. Or any corner, like this, they could hold on to. You're just going to do more of an anterior capsule stretch. They may need to start low, but I can start a little bit higher, keeping my shoulders square. I just lean into it for that same anterior capsule stretch. Again, how often are they doing all these things? 10 times an hour. For the elbow, typically, and I'm talking elbow, not medial lateral condylitis, it gets a little different. If someone has a loss of extension, plus they have just a bit of loss of that last joint play. This is one of the few bone-on-bone joints. This is bony end feel. Should be bony approximation here. But people who have that loss, and one of you may have it, so quickly check. If anyone has a loss, and also overpressure into the end range. Someone's had it at each class so far this weekend. You overpressure into the end range. If there's a springy end feel, that means you have that capsular infold or growth. So you need to get rid of that with repeated loaded extension. If there is medial or lateral pain, if there's lateral pain, you can give a little lateral glide and do that to make it feel better. If there's medial pain, you can give a medial glide. But if that was painful, the problem with having that loss of extension, if it's really due to a capsular infold, that's innervated capsule. I've manipulated a guy once, the very first guy I ever did this on, big biker dude, really scary. He had a lot of elbow pain after an accident, loss of extension. I tried tons of tissue work. I was doing humeral ulnar mobs, humeral radial mobs, all the typical stuff I was doing back then. So I said, well, there's this manipulation. I did a Mills manipulation on him. I told him, he might be a little sore. It turns out he was super sore. There was a huge cavitation, which I don't even know if it was a cavitation, because it was more like me obliterating innervated capsule between two bones. And he just started swearing. He said he was going to throw me through an effing wall, and he was going on and on. The whole clinic kind of stopped, and people dropped their exercise equipment. But he was actually really happy the next day, and he returned and he got me a gift. Because he was completely pain-free and he had extension. But my new informed consent is when I have to do that on someone, is this might be very painful, and I can't even say it's only going to be a second like a cervical thrust. Because that's not really smashing innervated capsule, but this could be. Because it's not bony, when you have to do this, it's springy. But you can't give them the option of repeated extension. For the forearm, most people are in pronation, so it ends up being supination, and I like to do end range supination. And that's just a good part of this kind of stretch, or this kind of stretch like a Praeger's. I just like to do that all day, because that's just a reset for this, right? For the wrist, it usually is extension, because most people are in flexion, although there is, for de Quervains, I had a problem with de Quervains, and we'll go over that in a second, but loaded wrist extension seems to work better than just passive wrist extension. And again, with this, you can give a P to A glide, you can give a lateral or a medial glide, just to make that a little bit better. Whatever makes it better, and you just teach your patient how to do that, all 10 times an hour. Now my story is, I was training for a Russian kettlebell challenge. So you're supposed to be able to take like a 50-pound kettlebell and do repeated snatches for 5 minutes. And if you know how to do the snatch correctly, it's supposed to land ever so gently on your wrist. So you have to have perfect form. In my dominant side, I can make it land very softly. My non-dominant side, with a DN or dysfunctional, non-painful loss of motion in my ankle, my hip, my thoracic spine, my glenohumeral joint, my forearm, how, with all that dysfunction, was I supposedly, and also with my weaker side, because it's my non-dominant, how could I have possibly prevented that from extending my wrist? So the higher I got into weight, the more I started getting wrist pain. At first I thought I had a fracture here because that's where it was hitting. But it turns out that was my extensor carpi radialis brevis when I actually looked it up, and after I got an x-ray, it was negative. I had so much swelling in my anatomical snuff box that it eventually became a convexity, not a concavity. And because I'm Mr. Eclectic, I tried radial patterns, radial mobes, thumb mobes, cervical thrust, loading that side, thoracic thrust, T4, whips. All after 2 weeks, which is enough, like say 6 visits, my partner was treating me, I didn't get any better. In fact, I got worse. The swelling got worse. I splinted it. My pain and swelling got worse. I got chastised by an OT in my first course who said I didn't get a custom splint. But I don't think that would have made it better, because that movement made it better, eventually. I got a cortisone injection that made it all go away in a couple of days. Then I came back several months later when I was carrying double strollers at Disney every time I got in and out of the bus all day for a week. Then with the nor'easter, it came through in October, my basement flooded, and that's when it really worsened. I was just taking stuff out of my basement. So I decided to head it off at the pass. I knew nothing was going to work. I got a cortisone injection, only to my surprise, this one did not work. And by then I could barely move my hand in any direction. So I don't remember what made me try this, but I tried repeated loaded flexion after I was reading my daughter a story. And I couldn't believe that, of course it was pain during movement, but only after about 20 reps, almost all my pain went away. And I found that if I still do this actually all day, because every once in a while it just comes back just a little bit. If I flex and put a little bit more pressure on the radial side, it reduces it faster. So between that and a to P at my distal radial ulnar, it got completely rid of it. And that's pretty much exactly the opposite of the kettlebell coming around, swinging me, hitting my radius that way, and my wrist going into extension. So wrist extension as a reset didn't work for me, but that's because that was what was already happening. It was wrist flexion. Now I have an N of 3 that shows that helps. So I tried it on 2 other de Quervain's patients since that happened to me last year, and it did actually help them. So I just encourage you guys to try that. Try wrist extension first, except for de Quervain's. We don't know why these people get de Quervain's, whatever their mechanism is. So it did help too, my patients. And one of them is actually a cervical patient who, she had pain. It started here, then eventually went up to here. Loading in this direction got rid of her arm pain, but it didn't get rid of this. The only thing that got rid of this was this. Then she had residual lateral epicondylon, and radial paddles ended up helping. Okay, so wrist flexion for that. For cervical, if it's bilateral symmetrical, you're looking at retraction, then progressing after a couple visits if it's not fully gone, to retraction and loaded overpressure. And you want to do that until the sternum goes up. That's the way you're sure of getting end range. And when the sternum goes up, remember again, so the instruction is push far and not hard. After that, if they are better but not fully gone, so they need to load more, it's retraction with extension, and then a little wiggle, 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 wiggle. Those wiggles, you just go a little further. A lot of people who try that, try it right now. Everyone's gonna be like, oh, my CT junction, oh, my CT junction. So if you can do that, and the CT junction doesn't hurt, good for you. But for everyone who's been sitting here all day, try this instead. Just pull lightly. Mulligan used to say, pull on the facet. You don't even need to pull on the facets. Because it's probably a skin thing, just pull lightly on the skin and push medially on the skin of the upper traps. And then try the same thing. How much better does that feel? Better? Yeah. I wonder why I don't allow patients to do this in the first time. So the thing with that, and I got this from a diplomat, Frank Ward, you may not get to end range. This might block it just a little bit. So at the end, let go, and then you get a little bit more end range. And then you can do the wiggle. That also 10 times an hour. If it's unilateral load, or unilateral symptoms I should say, try loading the same side first. Remember end range is important. They should typically pull, if possible, with the same arm because there's just more leverage than there is with that side. If they're getting some upper trap issues, you can have them lean, slack somehow. Someone in class did this today. I thought that was cool. So you could just slack this side, then they can go further. It's okay if the left upper trap hurts, as in anything of these recites. It's okay if any of this hurts, as long as you can walk it off. Yellow light. That's if it's lower, or if it's radiating into the arm. If it's not radiating into the arm, or if it's upper cervical, unilateral, or unilateral headache, retract, rotate. If someone has end range pain with rotation, Mulligan would say that you could try pushing AA anteriorly toward the eye on the opposite side. And he said if that doesn't work, try the ipsilateral side. And that never made sense to me, but since I've been doing so much MDT, it makes sense to me now. I still don't exactly know why it works, but for some reason, you'd think that pulling this AA would make it feel better. I mean, I don't know if you guys notice I'm moving further. When I do it like this, it feels much easier. So if I can push a little bit forward on this AA and go a little bit further and it feels better to me, I'm going to do it like that. That's an easy thing to teach your patients. He does it with a towel. As long as they have hands that can do it, that's fine. The towel will just wrap around, pull forward, and you do it like that. Except for they won't be able to get the overpressure with the hand because the other hand they're pulling the towel in the opposite direction. All right. For median nerve and ulnar nerve, you can do the Praeger Stretch. So the key with the Praeger Stretch is end range, right? And you also want to make sure that the patient retracts the scapula. Because this is a very easy thing. Like, I don't really feel anything. And this in itself could be a slider. But if you really want it to be a tensioner, palms together, this is what a patient would do. Exactly, because it's difficult. Lack of wrist extension or lack of neurodynamic mobility. I tell patients to lightly press the palms together. You'll definitely feel a difference. Between that and retraction and scapular depression, I can feel a difference on the more symptomatic side, my left versus my right. I don't necessarily say do this 10 times an hour, but you do it repeatedly throughout the day. And I do not hold. You getting a little tingling?
Yeah.
Yeah. Okay. So you can also do that. It kind of mobilizes both nerves as well. But this I feel in median and ulnar. It is difficult for a patient to do their own ulnar mobs. That's why I don't really stick with that.
That one.
Yeah, the eyeglasses one. It's like I don't have enough motion for that. Here, do this. I can't, but I want you to do this. You know, that's probably why I don't demonstrate that. But I have told a patient to take their hand and do that, which is similar. It's hard to make a slider out of this one because you can't really side bend toward it because you're already bringing your hand toward your head. So the radial paddle is, because you want to do an internal rotation, reach, pronate, and flex the wrist and flex the thumb. So they can make a paddle out of it. I think like you're paddling in an inner tube. You should get a stretch along here posteriorly. You can make that a slider.
Now, somebody with tennis elbow going to be able to tolerate this in the acute stages?
Depends. I mean, to me, what's acute? If you can rapidly change it, right? If they can't tolerate, it's always red. It's always stoplight. Always stoplight, no matter what. You never know. Maybe it'll make them rapidly better. But if it's really acute inflammatory, as in like chemical first couple of days, probably not. So with that, with either say a golfer's or tendinopathy or lateral epicondylalgia, medial or lateral, eccentric loading works very well as well. So, I mean, we take away from those studies that Alfredson did for the Achilles, and you can just do passive on the way up, eccentric on the way down. Passive on the way up, eccentric on the way down. Just like the Achilles eccentric loading. So remember, if a patient is not tolerating something like a median nerve, which would be also a median nerve stretch, I prefer this because it's a little easier for me to do. If it's not tolerating this and they're doing a neutral, make it a slider. And I can instantly feel better, which decreases the perceived threat because I feel, now this is a comfortable motion. They could alternatively slide like this. I don't really teach this one a lot though. I've even taught, you really want a nervous system? You could do this. And if I wanted to tension everything, like tension the left, I could do this. And then now tension the right, tension left, tension right. And I've really wound it up on some people who are super flexible. You could do that, but that was usually in lying. But in general, you get the point. Just the same thing you would do to a patient, but have them do it repeatedly at home to keep up with the neurophysiologic improvements you made. Now, if they have to, they could also work on their own patterns, maybe with a tool of their own or with their hands. But it's your job really to get those, to work on those patterns and make it more comfortable for them to do their self-mobilization. Whether using kinesio tape or rock tape, of course I prefer rock tape. You can tape along neural lines also, and that really seems to help. So here for the median, here for the radial, here for the ulnar. I do caution about taping across here. The instructor said at the rock tape course that this would be painful coming off, and literally I felt like it was pulling off my skin. My wife was like, "Suck it up, you baby." She went to go rip it off fast because I was taking it off so slow. It did not come off fast. It actually just made my skin come off really hard, and my skin just snapped back. And then I remembered the olive oil. So olive oil, if you're having trouble taking off rock tape, slather olive oil, massage it all over, and then after a couple minutes, just peels right off.